clicking now.
Okay. Good morning, everyone, and welcome to the May Group Insurance Commission meeting. I'm Valerie Sullivan. I'm chairman, and I'm joined by my esteemed group of commissioners. But before I introduce our folks here, I want to let everybody know that Erica Schiavelli is back from her recent leave, and thank the staff for the good work that they have been doing in her absence with the new procurement, getting contracts ready, and making sure that open enrollment was a very strong engagement with all of our stakeholders. So to our stakeholders and constituents who are on live stream, I want to welcome you here today and know that the staff of the GIC are constantly working to ensure that they are meeting and exceeding your expectations. So at this time, Andrew, could I ask you to run through who the commissioners are that we have on today's meeting?
Be happy to.
If not, I could do that as well, but I know you've been taking notes for the quorum, and I thought it might be a little easier, and we always like to hear from you.
Thank you. With us today, we have our chair, Valerie Sullivan, our vice chair, Commissioner Kaplan, our designee Butler for Department of Insurance, Commissioner Choate, Commissioner Kleinard, Commissioner Gentile, Commissioner Gare-and, Commissioner Murphy-Rodriguez, Commissioner Sinenko, and Commissioner Sullivan. And I think that's everybody who has joined so far.
Oh, well, that's terrific. Well, thanks and welcome again. So at this point, I'm going to turn the meeting over to Matt, our executive director, to walk us through the agenda.
Thank you, Madam Chair. Thank you, members of the commission. It's really terrific to see you all after our April break from commission while we focus on annual enrollment. Really thrilled to see you all again. So today we have a busy agenda in addition to minutes and highlights from the executive director's report. We have a presentation from Lauren Makashima, our data analytics manager, with our annual out-of-pocket report and some new features, some interesting additional elements to this year's report, particularly focusing on the impact of COVID. We will follow that by having Margaret Anschutz, our health policy and analytics director, to review where things stand on our behavioral health strategy. And we've talked high level in the past about our strategy here, but we are now actually starting to implement some elements to that. So some specific updates that you'll hear in that report. We've actually combined the out-of-pocket report and the behavioral health report because they really are linked, and we've heard from commissioners in prior meetings when we've presented on the out-of-pocket report a desire to understand better what we're doing about some of the things that we learn about that report, particularly in the behavioral health space. So we've heard that, and this year, that's why we've combined those two together. So they really are linked together in this presentation. We have our one vote for today, one substantive vote, aside from minutes on the trust funds, which Jim Rust, our CFO and Chief Procurement Officer, will run through in addition to his CFO report. So that's what we have today, a pretty busy agenda.
Oh, yeah, it looks great, Matt. Thank you. And again, I want to reiterate how hard everyone's been working to ensure that that our constituents are well taken care of in this changeover during open enrollment. So at this point, I'd like to entertain a motion to approve the minutes. But before I do that, I do know we have a new member of the commission that's representing A&F. Has Kushbush joined yet? She has not. So
Hi, Chair. I am helping to troubleshoot some technical difficulties she's having, and she'll be on shortly. I will let you
Okay.
know once she's joined.
Well, that's the way we acclimate and onboard our new commissioners. We make sure they have technical difficulty so that we can let them know they're just like the rest of us for the first time we log on. So when she joins, I want to make sure we introduce her. She's got an impressive background, and we're very lucky to have her representing A&F. So back to the motion. Do I have a motion to approve the minutes from our March meeting?
So moved.
Okay, so that sounded like Bobby. Do I have a second?
Toby Cho for a second.
Okay, I heard Toby and somebody else, so we've got a second. So at this point, I'd like to ask Andrew to take roll call, but for me, Andrew, I'm a aye.
Vice Chair Kaplan,
Aye.
Designee Butler,
Aye.
Commissioner Choate,
Aye.
Commissioner Cornard,
I'm going to abstain. I was not in attendance at the March 2nd meeting.
Commissioner Gentile,
Yes.
Commissioner Garand,
Yes.
Commissioner McEnany, who has joined us.
Yes. Yes.
Commissioner Murphy Rodriguez,
Yes.
Commissioner Sullivan,
Yes.
and Commissioner Sinenko.
Yes.
The motion passes.
All right, thank you, Andrew. We can move on to the next order of business.
Thank you, Madam Chair. I'll touch on a few elements of the written executive director's report. First, I'd like to echo your welcome back of Erica Schiavelli, Madam Chair, our deputy executive director from her maternity leave. Congratulations to Erica on welcoming Mari, her beautiful baby girl, who has delighted staff by making some cameo appearances during our virtual staff meetings, and just thrilled to have you back, Erica, and just thrilled with the new addition to your family. Since we have not met since March, as I said, we have a busy agenda today. So we've provided a detailed, rather lengthy executive director's report. In addition to a few items that I'll touch on here, it contains updates on human resources items, action on the municipal and legislative front, and again, a detailed breakdown of all of our communications and engagement efforts prior to and throughout this year's annual enrollment. So I encourage you to read through those, particularly the communications items. It really highlights all the different channels that we've used to alert members to the annual enrollment dates and give them tools that they need to navigate annual enrollment. As a result of these efforts, we had a very, very busy annual enrollment as members were highly engaged with us, which is good news. As we always do, at our June meeting, we will provide the Commission a comprehensive update on the annual enrollment. And as our team actually continues to do the back end work, accepting forms coming in through the mail, completing the enrollment process, all the work that needs to happen to make sure that coverage takes effect smoothly on July 1st. So look forward to that discussion. The GIC legal team continues to work on contracts with our health, pharmacy, FSA, and employee assistance program vendors, and anticipates having contracts ready for you all to sign in June. So if you have any questions about the contracts, please reach out directly to Andrew. And let's also make sure that your contact information that we have for you is updated. In order for you to sign the contracts, we will need to make sure we have an up-to-date email address. So we just want to make sure that you get those. Finally, commissioners are likely aware that on April 17th, Harvard Pilgrim Healthcare informed the GIC of a ransomware incident that significantly impacted their systems. So I want to say a few words about that. As soon as the incident was discovered, Harvard Pilgrim immediately took all their systems offline while they identified the nature and extent of the problem. Obviously, the timing for us was less than ideal since we were in the middle of annual enrollment, and it did temporarily disrupt the ability of some of our members to access Harvard Pilgrim's resources. However, within 2 days, we had worked closely with Harvard Pilgrim to find alternative methods to share this necessary information with our members. They were able to quickly stand up a new microsite on the Point32's website, and that included the all-important provider directory, and they got member services phones back up and running. At the same time, we at the GIC posted on our website information about the incident and also guidance for members, information about our benefits, and also alerted members through all of our communications channels on our website, by email, through our social media channels, and also with the assistance of our various stakeholder groups. So we certainly appreciate that. So during this time, during those 2 days, GIC members did continue to have the ability to view the GIC's benefit guides and other important information about their benefits and the health plans, including Harvard Pilgrim, all of that on our website. Members could also continue to access the My GIC link member portal to enroll in Harvard Pilgrim or any other plans for coverage for July 1st. The GIC, My GIC link and other GIC systems were not impacted by this incident. Point32 and GIC have also implemented some temporary procedures for common enrollment transactions that continue even outside of annual enrollment, so new hires, births, marriages, and those sorts of things. And we remain in very close contact with Point32 as they restore all their systems, their capabilities, and maintain continuity of services. So with that, happy to take any questions on the items I've highlighted or anything else that you've read in the written executive director's report.
Matt, I don't see any questions. So I think it's a good time, maybe. Oh, I see Bobby. Your hand is up. Did it come down quickly? Go ahead, Bobby. Are you on mute?
Nope.
Sorry, I was muted. Sorry.
Okay.
Good morning, everyone. I also wanted to congratulate Erica. It's great news. Nice to have a new member, always, regardless of age. And I just want to compliment GIC staff, particularly regarding the announcement of the ransomware attack, as well as the enrollment period, because, you know, aside from a few little sort of bumps in the road, which happens anyway, everyone, staff did a tremendous job getting the messaging out by every medium possible, I think. And, with the enrollment sessions, I've heard nothing but, praise actually for the GIC. And also I want to specifically thank Paul Murphy and his terrific team, for fixing issues immediately and just responding so quickly. They're just amazing. And I just wanted to thank everyone for making this, which was a very, very changeable year, just pretty seamless. It ran really well. So my thanks to Paul and everyone at GIC. And Matt, thank you for being at the helm.
Yes, nicely said, Bobby.
Yeah, thank you for that, Madam Vice Chair. I'm extremely proud of our staff, their hard work and their dedication. Annual enrollment, even a normal annual enrollment, is an enterprise-wide activity. It's really all hands on deck for us. And while the operations team handles the brunt of that and performed extremely well, we had others across the team chipping in to assist on a variety of issues. So thank you for that acknowledgement, and it's much appreciated.
Yes, no, and justly deserved by the team. And I really like how everyone works together. So that is really terrific. Hey, at this point, it does look like our newest commissioner has joined, Khushbu Weber. Welcome, Khushbu. Want to say hello?
Good morning. I'm so sorry for my tardiness. Technology, always, the struggle.
It's how we indoctrinate new commissioners, so you can blame it on us. But it is wonderful to have you. Your background is impressive since you've graduated from Suffolk Law. You've been involved in so many different great causes and in our government. So thank you for that. You are joining as the designee for ANF, and currently you're Deputy General Counsel at ANF. So welcome.
Thank you.
Happy to have you say a few words.
Oh, sure. Thanks, everyone. I'm really looking forward to working with you all. And I'm sorry to, throw off the agenda here.
Not at all. So welcome. So, all right, Matt, let's move on to the next item of business.
All right. Welcome, Khushbu. We're thrilled to have you. So we'll move on to the review of our calendar. So looking ahead to June, as I mentioned earlier, we will provide the Commission with a recap of annual enrollment. As in the past, this will include a lot of data to show the results of plan selections, as well as the methods our members use to make those selections. As I may have noted, we had very heavy use of the My GIC Link member portal this year, which is very encouraging. It performed well. So we're eager to present those statistics, as well as more data to illustrate the impact of all of our various engagement efforts throughout this process. We've done a number of new things this year on top of just the scale of changes to our plans. And so we'll be happy to come back with more detail on that. Beyond the member portal, we have lots of activity we have had throughout this, really for quite some time, but also throughout all the run up to annual enrollment. Lots of activity ongoing on the modernization front that we want to bring you up to speed on. And so Paul Murphy and our IT lead, Stephanie Sutliff, will present on that. And finally, our data analytics team will be back to provide an update on carrier performance guarantees. This is a really important element of us holding our carriers accountable to their commitments to help us achieve our goals across, the strategic priorities we're all familiar with: affordability, health equity, and behavioral health. After June, per our normal calendar, we'll take our break for the summer with no meetings in July and August, and we'll reconvene in September. So happy to take any questions you may have on the calendar, which we will continue to populate as we go through the summer months into the fall.
Yep, you can keep moving. I don't see any questions.
All right, with that, I am pleased to introduce Lauren Makashima, our data analytics manager, fantastic addition to the GIC team, and Margaret Anschutz, our health policy and analytics director, to present the out-of-pocket report, followed by an update on implementation of the behavioral health roadmap. So with that, turn it over to Lauren.
Thank you, Matt. Good morning, commissioners. My name is Lauren Makishima, and I'm the data analytics manager here at the GIC. It's a pleasure to be able to join you all again this year to present out-of-pocket spending data for fiscal year 2022, which runs from July 1st, 2021 through June 30th, 2022. Feel free to jump in with questions or raise your hand in Zoom, but I'm going to keep us moving at a pretty brisk pace just to make sure we can get through everything. Before I dive in, as Matt mentioned, this report is going to be followed by a behavioral health update, which I'm really excited about this year because behavioral health always sort of rises to the top as one of the main drivers of out-of-pocket costs. So we're excited to be able to present some updates and some supports that will be available to members.
Yeah, so it's very nice to have you here today, Lauren. And I'm going to ask my commissioners to let Lauren work through the entire presentation before we take questions. How's that sound? Just to make sure that we stay on point, but also we have confidence that Lauren's going to get to the information. And if she doesn't by the end, we'll ask questions. So let's try that.
That sounds good. Thank you,
You're
Madam
up,
Chair.
Lauren.
All right. Can we go to the next slide, please? Thank you. Okay, so I'm just going to start with a quick refresher on what out-of-pocket costs are and how our plans are structured with regards to these costs. So out-of-pocket costs are the portion of costs for medical and pharmacy services that are paid by the member, and they include deductibles, copays, and coinsurance. Once a member's medical and pharmacy costs combined reach the out-of-pocket max, the GIC covers 100% of the cost of that member's covered services. All non-Medicare GIC plans have a $5,000 in-network out-of-pocket max for individual policies and a $10,000 in-network out-of-pocket max for family policies. For a family policy, no single member's in-network out-of-pocket costs will exceed $5,000. And it's important to note that plans that have out-of-network benefits have a separate $5,000 individual and $10,000 family out-of-pocket max that only applies to out-of-network services. Most of this report will be focused on members with high out-of-pocket costs. So I'd like to talk about some of the factors that could cause members to incur high out-of-pocket costs and even potentially exceed the plan's out-of-pocket max amount. Broadly speaking, utilization outside of plan parameters is the main way that we see members exposed to high out-of-pocket costs. A major example of that is seeking care from a provider that's out of network for non-emergent care or without pre-authorization. For limited network or HMO plans, services provided by an out-of-network provider are not covered. And for plans with broad networks or PPO type plans, out-of-network providers are covered, but are subject to higher cost sharing levels and a separate out-of-network deductible and out-of-pocket max that accrue independently from the in-network deductible and out-of-pocket max. So an individual member could theoretically reach their in-network out-of-pocket max of $5,000 and then seek care out-of-network and be responsible for additional coinsurance or copays that results in the total out-of-pocket spending within the plan year exceeding $5,000. Many out-of-network services have 20% coinsurance after meeting the separate out-of-network deductible. And those coinsurance amounts can be costly depending on the type of service. This is why we always encourage members to confirm that their providers are in network when they're selecting a plan at open enrollment. Next slide, please. Oh, I apologize. Can we go back one slide? Thank you. Okay. On the pharmacy side, an example of utilization outside of plan parameters would be filling a brand name drug when there is a generic equivalent available. In this scenario, the patient is responsible for the cost difference between the brand name and generic drug, in addition to the generic copay. This is called the product selection penalty, and the penalty amount does not apply to the out-of-pocket max. As we discussed at length in last year's report, it's often unclear whether the patient is actually paying the product selection penalty or not because of the availability of manufacturer coupons, which are sometimes called copay assistance programs or discount programs. Drug manufacturers may offer these programs for new or high-cost brand name drugs, especially when there's competition from other manufacturers. These programs cover the entire penalty amount so that the member is actually only paying a small copay out of pocket at the pharmacy. In these instances, we usually don't get any data from the pharmacy that shows that a coupon was used, so this report assumes that patients paid the full amount, even though that's likely not always the case. We'll take a closer look at some of these instances a little later in the presentation. Another example of utilization outside plan parameters would be repeatedly filling a 1-month supply of a maintenance medication at a retail pharmacy. Maintenance medications are usually for chronic conditions, for example, drugs to treat high blood pressure or cholesterol, and are typically taken on an ongoing basis. Coverage for these medications is limited to 2 30-day supply fills at a retail pharmacy. After that point, the member is expected to order a 90-day supply of their medication through home delivery. If the member continues to fill 1-month supplies at a retail pharmacy, the member will be responsible for the full cost of the medication. This is called the retail refill penalty, and it also does not count towards the out-of-pocket max. Depending on the drug, some members may use manufacturer coupons to avoid paying the retail refill penalty. Another factor at play in this scenario is members with VA benefits who can fill their prescriptions at any VA pharmacy with no cost sharing. The VA pharmacies are considered retail, so the retail refill penalty would apply, but the VA pharmacy does not actually collect the penalty, so the member's actually not liable for that amount. Again, this report assumes that the members paid the full penalty amount when calculating out-of-pocket costs, since we're unable to definitively determine whether coupons or other coverage were used. Finally, we have non-covered services. Members are responsible for the full cost of non-covered services or services that are not medically necessary under the plan parameters. This would include acupuncture or certain cosmetic procedures. And we wouldn't see this in our data since this is typically not processed through health plan claims. And on the pharmacy side, the member is responsible for the full cost of drugs that are excluded from the formulary, and manufacturer coupons may also be used in these instances. All right, next slide, please. Okay, so diving right into the data, total out-of-pocket costs for all GIC members, including Medicare and non-Medicare, increased 9.1% to $302 million in fiscal year 2022. This increase was expected as utilization and out-of-pocket costs returned to pre-pandemic levels. We can see here that out-of-pocket spending was depressed in fiscal year 2020 due to decreased utilization at the start of the COVID-19 pandemic, and in fiscal year 2021 due to policies that waived all cost sharing for telehealth services. In fiscal year 2022, copays for telehealth services were reinstated with the exception of COVID-19 treatment, which contributed to the increase. Aggregate out-of-pocket costs remain slightly below fiscal year 2019 levels. And we'll look at the impact of the pandemic and the waived copay policies more closely in a couple slides. Next slide, please. On a per household basis, the average out-of-pocket cost was $1,324 in fiscal year 2022, which amounts to an 8.2% or $100 increase from the fiscal year 2021 average. Fiscal year 2022 out-of-pocket cost per household also stayed below fiscal year 2019 levels. Next slide, please. Okay, so this slide is new this year. If we break this down into out-of-pocket costs per member per month and separate that out by Medicare and non-Medicare members, we see that out-of-pocket costs have been fairly stable over the last 4 years. Medicare members have very low medical out-of-pocket costs. However, Medicare members tend to utilize many more prescription drugs than younger non-Medicare members, resulting in a higher share of prescription drug out-of-pocket costs. Average Medicare out-of-pocket costs decreased slightly over the four-year time period, while average non-Medicare costs were relatively stable, increasing about $1 per member per month. In a couple slides, we'll also look at how the GIC's out-of-pocket costs compare to those for non-GIC members in Massachusetts. Next slide, please. Okay, so returning to the topic of COVID-19 impacts, starting from the top left-hand side, you'll see the blue line on this graph that shows the aggregate GIC paid claims for the last 4 fiscal years. You'll see that first, paid claims decreased 5.3% between fiscal year 2019 and fiscal year 2020. And again, this decrease was due to the sharp decline in utilization during the first few months of the COVID-19 pandemic, as appointments and elective procedures were canceled. Starting in July 2020, which coincided with the beginning of fiscal year 2021, utilization began to rebound as patients returned to doctors' offices and hospitals to receive care that had been deferred. And this rebound continued through fiscal year 2022, resulting in GIC paid claims that were 13.2% higher in fiscal year 2022 than in fiscal year 19. The bars along the bottom of this graph reflect out-of-pocket costs, with deductibles in green, coinsurance in yellow, and copays in purple. The graph to the right shows these components in greater detail. So what this graph is showing us on the right-hand side is that changes in copays really drove the changes in the overall out-of-pocket costs. In March 2020, GIC waived cost sharing for all telemedicine services, as well as COVID-19 testing and treatment. Utilization decreased significantly at the end of fiscal year 2020, resulting in that low amount in fiscal year 20. Then in fiscal year 2021, even as utilization rebounded as members received services that had been delayed, copay amounts paid in aggregate remained low due to the waived copay policy. Then in fiscal year 2022, when cost sharing was reinstated for telemedicine services, there was an increase in aggregate copays, which was expected. However, the GIC also added a new benefit in fiscal year 2022 to waive cost sharing for the first 3 telehealth outpatient behavioral health visits. So that also helped to protect members from out-of-pocket costs. The net effect of all of these changes is that aggregate copays increased in fiscal year 2022, but remained 7.7% below pre-pandemic fiscal year 2019 levels. Next slide, please. So in looking at how GIC benefits compare to other large plans nationally and within the industry, this data from the Willis Towers Watson 2022 Financial Benchmark Survey shows that GIC members are responsible for an average of 8% of total costs. That's the pink slice in the pie chart on the bottom right. And that's below the overall database average of 14% of total costs and below the industry average of 11% of total costs. The bar charts show these same figures in dollars, although it's important to note that the dollars for the benchmarks are unadjusted for factors where they may differ from the GIC, like age, gender, family size, and geography. Next, we'll take a look at how GIC members' member costs compare to other members in Massachusetts. Next slide, please. So this is a slide from CHIA's annual report that compares calendar year 2021 member cost sharing for all private commercial members who were enrolled in a plan Situs in Massachusetts. CHIA reported that on average, GIC members spent $10 less per member per month than Jumbo Group members who receive benefits through employers with over 500 employees. The dollar amounts differ slightly from the amounts previously shown because CHIA's figures don't include benefits that are carved out, which means prescription drugs are not included for the GIC. However, many large self-insured employers also carve out prescription drugs or behavioral health benefits. So although the member cost sharing figures may not be complete, the differences across GIC and other large groups are still a valid benchmark metric. Okay, next slide, please. So this slide shows a distribution of households by their fiscal 2021 plan year out-of-pocket costs. And we'll show fiscal year 2022 on the next slide. So just in terms of how to read this graph, we've got the number of households in purple with the vertical axis to the left and the brackets for out-of-pocket spending levels along the horizontal axis. And then we've got the yellow line with the vertical axis on the right, which represents the cumulative percent of total households in each bracket, or in other words, the percent of households that fall above or below that particular spending bracket. So in fiscal year 2021, the median out-of-pocket household cost was $966, meaning that half of households spent more than $966 during the plan year, and the other half of households spent less than that amount. The average out-of-pocket spending per household for this year was $1,224. Next slide, please. So here we're comparing that with fiscal year 2022 spending, where the median out-of-pocket household spending increased to $1,049, and the average out-of-pocket spending per household increased $100 to $1,324. Again, these increases were expected due to the reinstatement of copays that had been waived during fiscal year 2021. Next slide, please. Okay, so the next section of the report will focus on the relatively small number of households in the box in green here that had greater than $5,000 in out-of-pocket costs. And we'll take a look at the drivers behind that high out-of-pocket spending. Okay, so this chart shows the distribution of the 3,493 households that had at least $5,000 in out-of-pocket costs. The color of the bars indicates whether it was an individual policy in yellow or a family policy in purple. As a reminder, the in-network out-of-pocket max is $5,000 for individuals and $10,000 for families. The total households in this graph represent 1.6% of all of the households that had GIC coverage in fiscal year 2022. Next slide, please. So this is just a summary, and I won't read all of these numbers to you out loud, but the overall number of households with out-of-pocket costs exceeding $5,000 increased from 2,467 households in fiscal year 21 to 3,344 households in fiscal year 22. On average, the GIC covered over $113,000 in medical and pharmacy claims for households with between $5,000 and $10,000 in out-of-pocket costs, and over $187,000 in claims for households with over $10,000 in out-of-pocket costs. This demonstrates that, as you might expect, members who end up in this category typically have very intensive healthcare needs with high total costs. In a few slides, we'll take a look at some of the clinical conditions that were experienced by members with the highest out-of-pocket costs. And finally, out-of-network utilization and pharmacy penalties are a big part of this story of high out-of-pocket costs, and we'll explore those factors in the next couple sections of the report. Okay, so this is similar to the aggregate total out-of-pocket graphs that we looked at the beginning of the report. So looking at aggregate medical and pharmacy out-of-pocket costs for all GIC members. We can see that there's been a consistent proportion of costs incurred out of network at about 12% over the last few plan years. If we limit this to medical out-of-pocket costs only, that percentage is about 17%. There are a lot of reasons why a member might seek services out of network. Some members may not be aware ahead of time that the provider that they're seeing is out of network. For example, if their in-network PCP refers them to a specialist, they may assume that that specialist is also in network when that's not always the case. Some members may actively choose to seek services out of network, sometimes due to a lack of in-network provider availability, or because they have an existing relationship with a provider that happens to be out of network, or sometimes because it's easier for them to travel to a provider that's out of network, but close to their home. Members that receive services out of network will typically incur higher out-of-pocket costs than if they saw an in-network provider, because they have to meet the separate deductible and out-of-pocket max, and because the out-of-network benefits typically have a 20% coinsurance, where the in-network benefit would have been a flat copay. Depending on the type of service, the coinsurance amounts may be significantly higher than the in-network copay, which is again why we always encourage members to double check that their providers are in-network, both at annual enrollment and before receiving a service. Next slide, please. Okay. So we talked at the beginning of this presentation about utilization outside plan parameters being a driver of high out-of-pocket costs. This graph visualizes out-of-network spending by color, with purple representing 17% of medical out-of-pocket costs incurred out of network, and yellow representing up to 31% of medical out-of-pocket costs incurred out of network. We can see that the average percentages of out-of-network costs increase from left to right across the out-of-pocket spending brackets, and that just demonstrates a correlation between households that have high out-of-network utilization and high out-of-pocket costs. Next, we'll take a look at the small number of members with the highest out-of-pocket costs and talk about the drivers of cost for each of those members. First, we'll look at members with high medical out-of-pocket costs, and then a few slides later, we'll also take a look at the same graphs for members with high prescription drug out-of-pocket costs. Next slide, please. So every year in preparation for this report, we make a list of the members with the highest out-of-pocket costs and send those lists to the carriers that they were enrolled with, so that the carriers can provide more information as to why that member incurred those high costs. This year, we requested information on 64 members who had high medical out-of-pocket costs, and those members collectively had over $500,000 in out-of-pocket. The top set of bars breaks down membership by the cost driver, and the bottom set of bars breaks down the spending by those same cost drivers. In this graph, we categorized all medical out-of-pocket costs for each member under the main driver of those high costs, although those amounts may include some spending that was not associated with the main cost driver condition. So the largest cost driver by both membership and spending was out-of-network spending, which accounted for 53 members and 86% of out-of-pocket costs. 30 of those members had high out-of-network spending for behavioral health conditions. Breaking those 30 members down further, 16 members had high out-of-pocket costs due to out-of-network treatment for mental health conditions, including anxiety, depression, and eating disorders, or due to out-of-network applied behavioral analysis treatment for autism spectrum disorder. Those 16 members incurred 25% of the out-of-pocket costs seen here. 14 members incurred 23% of these costs due to out-of-network substance use disorder treatment, which includes residential alcohol and opioid use disorder treatment at out-of-network facilities. A number of the members who sought substance use disorder treatment were dependents under the age of 30. The out-of-network other category includes conditions such as cancer, cardiovascular disease, diabetes, hemophilia, surgery, and high-risk delivery at out-of-network hospitals. And the other medical category includes in-network services related to cardiovascular disease, stroke, cancer, infections, and cystic fibrosis. So really the main takeaway from this slide is that the number one driver for high out-of-pocket costs is for out-of-network behavioral health treatment. We know that this is a challenge not only for GIC members, but for patients across the state and across the country. And that's why directly after my presentation, Margaret's going to speak more to the statewide efforts in this area and how the GIC is helping to support those efforts. Next slide, please. Okay, so I'm going to take a couple slides to quickly address prescription drug out-of-pocket costs, and then we'll sort of return to the topic of behavioral health spending before I wrap up and hand the presentation over to Margaret. So this is returning to our breakdown of households with out-of-pocket costs over $5,000. The yellow here represents households that would not have exceeded that $5,000 threshold if pharmacy penalties had been subtracted out of their out-of-pocket costs. About 308 households, or 9% of the total households shown here, fall into this category. The bar on the far right shows that a quarter of the households in the 10,000 plus out-of-pocket cost bracket would have had less than $5,000 in out-of-pocket costs if not for the pharmacy penalties. As a reminder, it's likely that some or possibly all of the households in yellow here were accessing manufacturer coupons or other coverage, which wouldn't appear in our data. Next slide, please. Okay, so this is the prescription drug version of the medical high out-of-pocket costs graphs that we looked at earlier. We requested information on 34 members with the highest prescription drug out-of-pocket costs, and collectively they had just over $1 million in out-of-pocket spending. You can see that all of these members had utilization outside of plan parameters as the primary reason for high out-of-pocket costs. 19 members had product selection penalties as the cost driver, and breaking that down further, 12 members incurred product selection penalties for anticonvulsant drugs for seizure disorders, and those 12 members incurred half of the total out-of-pocket costs for this patient population. As we discussed in last year's report, some of these patients have a rare and severe form of pediatric onset epilepsy called Lennox-Gastaut syndrome. The first-line therapy for this disease is anticonvulsant drugs. However, patient responses to different anticonvulsant drugs vary widely, and patients may need to try several different drugs to find a regimen that treats their specific symptoms. Several of the drugs with the highest product selection penalties in this category do have manufacturer coupons available, and while we have no way of knowing for sure, we believe it's likely that most, if not all, of these members used coupons given the high penalty amounts. And while we don't currently have access to data on manufacturer coupons, we did include a requirement in the upcoming PBM contract that the vendor must provide manufacturer coupon data at the claim line level to the extent that this information is known to the PBM. So we do hope to eventually be able to report on this area in more detail and with more specificity. And the other data point worth noting on this graph is that the one member who filled prescriptions at a VA pharmacy, this one member incurred 13% of the total out-of-pocket costs shown, primarily due to retail refill penalties. However, because the scripts were filled at the VA, we know that this member did not actually pay these costs. Next slide, please. Okay, so here we're looking at the distribution of aggregate prescription drug out-of-pocket costs among high out-of-pocket households with, on the top set of bars, $5,000 to $10,000 in out-of-pocket costs, and on the bottom set of bars, the highest out-of-pocket households with $10,000 or greater in out-of-pocket costs. The color of the bars indicates the type of spending, with copay and deductible dollars in purple, product selection penalties in green, and retail refill penalties in blue. We've divided each set of bars by brand status along the left-hand side, including single-source brand drugs, multi-source brand drugs, generic drugs, and specialty drugs, and over-the-counter. So looking at the bottom set of bars, we can see that the product selection penalties in green are often incurred when filling multi-source brand drugs. However, we know that this is also where manufacturers are incentivized to offer coupons in order to drive utilization of their drugs for conditions where patients and doctors have other options for prescribing. And the anticonvulsant drugs that we discussed on the last slide account for the majority of this spending. We can also see that the retail refill penalties in blue were concentrated in single source brand and specialty drugs. This makes sense given that these drugs are typically much more expensive than generic drugs, so the penalty amounts incurred are much higher for these categories. We do know that $129,000 of the retail refill penalties for specialty drugs in the bottom set of bars were incurred at VA pharmacies. Which means that the members were not responsible for paying these penalties. Of the $94,000 in single source brand retail refill penalties for the highest out-of-pocket costs households, a little less than half of that was incurred for brand name diabetes drugs, including insulin brands like Humalog and Trulicity. And several of these manufacturers for these brand name drugs do have manufacturer coupons or discounts available. And we hope to be able to provide more insight into coupon usage in future reports.
Lauren, can I interrupt you just for a moment? Can you say a little to the commission about the retail refill penalty? Just a little bit about how it's designed and what it does.
Yeah, so the retail refill penalty is designed to incentivize members to receive their maintenance medications in 90-day supply quantities through home delivery. This is more efficient both for the member and for the plan. And we know that these members will likely be on these drugs on an ongoing basis for a very long time. So the way the penalty works is members are allowed 2 30-day refills at a retail location, after which they're expected to switch to a 90-day supply through home delivery. And ESI will mail the member a letter informing them of the penalty and encouraging them to switch to home delivery. So that's typically how that penalty works and is incurred. And of course, as a reminder, as with everything else on this slide, we're not sure where coupons may have been used to offset those penalties.
And can you share, Lauren, what the actual penalty is? Do they pay more for each copay?
Yeah, so patients would be responsible for the entire cost of the drug in that scenario when they fill at a retail location.
Thank you.
We have very high, by comparison to other plan sponsors, we have very high mail order fulfillment, which as Lauren said is good for us, good for the member, more efficient.
Okay, thank you.
Were there any other questions before I move on here?
Yes. Actually, I didn't know if I should hold my questions till the end or ask them right now. But
okay, I'll do another.
Is it relative to the, this retail refill penalty that's been explained?
You're on mute, Bobby. Sorry.
Regarding our new mail order pharmacy, which will be Caremark. I'm just curious, for people who use CVS as their retail pharmacy, will Caremark, who is now going to be the mail order, will there be some sort of perhaps more interaction with the member? Because I do receive a lot of complaints about members being charged, for whatever reason, whether their doctor doesn't send the prescription to currently to Express Scripts, or wants to keep trying a medication that may become maintenance. I'm just curious if there will be more involvement, I guess, because it will be, CVS and Caremark for people who, exceed that twice, 2 times the 30-day scripts, because I do hear from a lot of people about that. And I'm just wondering if Caremark will sort of intervene, or they'll receive more than, one letter from GIC. I know it's a burden on GIC, but I'm curious if Caremark will take on some of that.
Sure. So I do know that
question. Sorry to interrupt, Lauren. So Caremark will operate similarly to Express Scripts. Members will receive letters if they have, if they're at risk of paying full price for a medication because of the penalty for the refill penalty after 2 fills. So it'll operate the same way, and everything should transition so that it's similar to how it works now. The GIC does not send those letters, that they come from the PBM. And if there's any issue, of course, they can contact the GIC or CBS, and then we can work it out.
Yeah, and we can take this back and address it perhaps at a future meeting to give a little more context on this, if that's helpful. I don't want to get too far off of the
No, I don't either.
report, but yeah.
But I think it's not very clear to people what happens if they, have a prescription filled more than twice for a particular or for what's considered a maintenance medication. So I don't know if our members have a clear understanding of that, of how it works and why. So I would appreciate you sort of, looking into that more.
Yep, we'll
And
certainly do that. Yeah.
And I have one more question regarding the out-of-pocket, Lauren, which I don't know if you can answer this, but I'm curious of those individual households and the family households that have incurred these out-of-pocket expenses. What percentage or how many of those households have flex spending accounts?
That's a really good question. I don't have that information available and linked up with our claims data, unfortunately, but we can definitely look into FSA enrollment numbers and provide those subsequent to this report.
That would be great, because I know the utilization and for FSA is not what it should be. And I'm curious whether these particular households have enrolled and if people really understand the benefit of enrolling in FSA. So I just wanted to raise that, and if we could explore that.
Yeah, unfortunately, there's not a good way to cross-check FSA enrollment against the data that is the claims data that's used to generate these reports. We'd have to look at actual individual names and or other personal identifying information in order to do that. There is no tracking for FSA enrollment within the Milliman warehouse, nor is it in Magic.
Oh, well, it does make a difference, right? Could there be a way to get that information?
Yeah, we'll take that back, Bobby.
Okay,
I understand your I understand where you're going here. For these people with significant out-of-pocket obligations, the FSA can be an important tool for them to manage that. So I understand what you're saying. Let's take that back and see if we can provide a little bit more insight there for you.
Thank you. I appreciate it.
All right, thanks for those questions. We'll go ahead to the next slide, please. All right. So for the last section of this report, we will do a deeper dive on the trends in behavioral health out-of-pocket spending and the impact of out-of-network utilization on out-of-pocket costs. And then I'll pause for questions at the end of the report. Next slide, please. Okay, so this slide shows all medical out-of-pocket costs for claims with a behavioral health primary diagnosis, and each bar represents one diagnosis category. The yellow here represents out-of-network, out-of-pocket costs. So we see similar trends here as we saw for those members with the highest out-of-pocket costs. You can see that 67% of out-of-pocket costs for alcohol-related disorder treatment and 43% of substance-related disorder treatment out-of-pocket costs are occurring out-of-network. The top two diagnosis categories by out-of-pocket costs here are anxiety and mood disorders. And for each of these categories, a third of out-of-pocket costs were incurred out-of-network. As we've discussed in prior reports, the supply of in-network providers has unfortunately not been able to meet the clinical demand for these services. And it can be incredibly burdensome for patients who need to find treatment to do the administrative work of calling multiple providers to find out whether that provider takes their insurance, whether that provider's in-network, whether that provider's accepting new patients, and of course, whether that provider is a good fit for their specific needs. So Margaret's section of the report will discuss the new types of services and supports that are becoming available to these patients through the implementation of the EOHHS Behavioral Health Roadmap. Next slide, please. Okay, here we'll take a closer look at the trends in mental health treatment for anxiety and mood disorders, specifically over the last 4 plan years. The left and right sets of bars have the same data, but they're split out in 2 different ways. So the left set of bars is split by in-network in purple and out-of-network in yellow. And the right set of bars is split by in-person services and blue and telehealth services in green. Going down the rows from top to bottom, we have utilization, out-of-pocket costs, and GIC paid amounts. So we'll start on the top left-hand side of this graph, where we see that utilization of mental health services has increased 30% over the 4-year period. On the top right-hand side, you can see that telehealth accounted for 0% of utilization in fiscal 19 and increased to 60% of all utilization by fiscal year 2022. So the increase in telehealth has been a big part of this story and a big part of increasing utilization overall. Looking at the middle row of bars for out-of-pocket costs, we can see that out-of-pocket costs dropped off steeply as copays for telehealth services were waived at the end of fiscal year 2020 and throughout fiscal year 2021. The good news story here is that utilization of mental health services remained high in fiscal year 2022, even as telehealth copays were reinstated, and that increased access to services through telehealth contributed to decreasing the proportion of out-of-network utilization from 45% in fiscal year 2019 to 22% in fiscal year 2022. So although telehealth has made strides in increasing access to these services, we know that this is still a pain point for members, and that's why we've decided to focus on it here in the report. Next slide, please. Okay, and here we're looking at a similar graph with the purple representing in-network and the yellow representing out-of-network for medical claims with a primary diagnosis of alcohol or substance use related disorder. And from the left to the right, we've got facility inpatient services, facility outpatient services, and professional services. So there's a lot going on here, but the finding that I found most concerning out of this graph is the piece that's highlighted in that green dashed line there. And this data point is telling us that out-of-pocket costs in fiscal year 2021 were about 50% out of network, and in fiscal year 2022, that proportion rose to about 81% of out-of-pocket costs out of network. Next slide, please. Okay, so reporting on substance use disorder facility utilization, we often get asked about what percentage of those claims are actually being incurred out of state. So we can see here, we've got our same bars for facility inpatient and facility outpatient, but here the green represents Massachusetts and the blue represents out-of-state services. And then again, we've got utilization, total out-of-pocket costs, and total paid. So looking at the top right-hand side, we can see that about a third of out-of-network utilization and out-of-pocket spending for facility outpatient services is also happening out of state. Next slide. Okay, so we've reached the end of my report, but before I hand the presentation over to Margaret, I'd just like to emphasize that while GIC members have access to benefits that provide relatively low cost sharing compared to the rest of the commercial market, we do recognize that out-of-pocket costs can still be burdensome for many families, and we're focused on addressing the drivers of those out-of-pocket costs. As we've seen, one of the areas that is most painful for members right now is behavioral health treatment, and the challenges in that area are structural and system-wide, which means we're going to need infrastructure changes at the system level to address those challenges. And I'll take any questions before handing it off.
Oh, thank you, Lauren. That was great. I see Eileen has her hand up, so go ahead, Eileen.
Good morning. Thank you, Lauren, for a very comprehensive and detailed report. I guess my question, though, is what in your mind are the key takeaways? Because I thought all of that data aligned pretty closely with general healthcare cost trends, and that the GIC was not an outlier in any area that I could see, and in fact, probably did better than a lot with respect to cost and some other things. So I guess, I mean, I'm just curious at the end of the day, like what are the key takeaways for this data?
Sure. So I'd say I would agree that GIC members have access to benefits that provide them with lower cost sharing responsibilities than many other members in the state. One of the main focuses for this report is to really focus on the members that are on the far right-hand side of that graph who do happen to incur high out-of-pocket expenses. So the focus on this report was really to more look at what can we do for those members who do experience out-of-pocket costs. But overall, I would say that GIC members have relatively low cost sharing compared to comparable populations.
Well, and I guess I would just say, I mean, and I did appreciate you were spending a lot of time on that, the far right folks, but I also think in any group situation, right, you're going to have a smaller percentage of people that typically drive cost, but I didn't see the cost drivers necessarily having anything to do with GIC plan design, right? I mean, some people are very sick and there's not much that we can do in that regard, right? Or people choose drugs outside of the network. Maybe they think the efficacy is better or, for whatever reason. But I didn't see anything begging for a GIC to change our plan design or what we're doing. So I guess I'm just curious why we spend so much time on that 1%.
Sure. I think the intention is just to acknowledge that out-of-pocket costs can still be a struggle for some households, but we can absolutely take that feedback into account for next year's report and focus more on sort of the average member's experience with out-of-pocket costs.
Thanks.
Yeah, I see Anna has her hand up. Hi, Anna. Good morning.
Hi, good morning, everyone. Thank you, Lauren and Margaret, for just excellent data analysis and a great presentation. And I just had one comment and actually really two comments. I think that I think it was really helpful to understand that the some of these penalties, the product selection penalties and the retail refill penalties might not be paid. I think that in the case of the VA, I guess it's just one patient now that we got through all this data. Like, I don't know. I feel like you could take that out of the spending because you actually know in that case that the VA person isn't paying the VA penalties. And so that seems like that could more accurately reflect what's going on. I also think it's great that you have contracted with the PBMs to try to provide data about coupon use, because I think that's a really important piece that we don't understand, and it would be really good to have that information. And then I think the comment I really wanted to make is that, I feel like there might be a distinction we might want to make for members who have these high out-of-pocket costs, but have chosen to have them because they understand what they're going to be spending and they choose a provider that's out of network sort of with full information, and that's worth it to them to pay that extra money to get the out-of-network provider, versus the members who are sort of surprised, right? And they didn't realize they would have this cost obligation, and that latter case is potentially more worrisome. And I would just encourage the GIC. I don't know how you do this exactly. I'd be happy to brainstorm with you, but some member outreach to try to understand if these higher out-of-pocket costs are surprising or if they've been chosen. Because I think if they've been chosen to be spent, then that's everyone's right to be able to spend their resources how they want to.
Absolutely. Thank you so much for that feedback. I absolutely agree that there's definitely a distinction between those two populations, between folks who are going out of network because they don't have other options, and then folks who are going out of network because they're choosing that. So we'll think more about how we can incorporate that into the data, although, as you noted, we might need some other data sources to sort of supplement what we have. Thank you.
Yeah. No, that was good commentary, Anna. So appreciate that. And I also wanted to comment that I thought Bobby's comment about FSA was important, because if these folks don't have not enrolled or maxed out on their FSA, I feel like that's an area of support that the GIC can provide to these patients, albeit, as Eileen mentioned, it's a very, very small number. But nonetheless, for those who struggle with these costs, it is important to note. All right, Bobby, go ahead.
Thank you, Valerie. I want to just say to Lauren, I appreciate this analysis that you've done, because it's eye-opening. And I think it's really important because it's our members, right? The members of the GIC, the subscribers and their families, who I hear from, and I'm sure my fellow labor commissioners hear the same from members, albeit a small number of households, still significant, that people are paying these huge, what I think are huge out-of-pocket expenses. So $10,000 for some may seem a small amount of out-of-pocket, but if your income is $50,000 a year, it's quite significant. So I just want to remind people about the members who are our subscribers, the members that I represent and my fellow labor commissioners represent, because those are the people who are incurring these high costs. And I sort of dislike, I guess, or take exception to the word choose, because everyone, without exception, that I have spoken to, any one of my members, they don't choose, their doctor chooses. So the specialists they are sent to are typically referred by their primary care physicians. And it's not like they're choosing to receive the care or seek services from some professional or specialist that their physician recommends. Most people are not that knowledgeable, right? And they're learning when they or a family member, their child, their spouse, is diagnosed with some condition. And we all want the best care that we can. So I think that becomes sort of secondary, that people don't think about it. And they are surprised at the cost, because people assume, I think, as Lauren mentioned earlier, that if your primary care refers you to a specialist, you assume that specialist is within network. And whether it's medical or behavioral health, the out-of-pocket costs are huge. Even $5,000 for an individual is a lot of money. And so I just want to remind people, this is the population, this is the demographics that we represent. These are public sector employees who are not compensated at the same level as non-public sector employees in doing the same work. And so I'm very curious whether EAP, particularly for behavioral health, if we have any data on whether, if that's been increased, the number of the utilization of EAP services, and whether people whether EAP is helping people to find a behavioral health specialist in network, essentially. And I know it's an industry-wide, it's a systemic problem, but I'm very curious because that might be helpful. To try to increase utilization, which I know we've been trying to do for a very long time.
Bobby, thank you
Yes.
for all of that commentary. Well noted. We do need to move on. We're about 15 minutes over on the agenda, if that's okay.
Yep, sorry about that. I know I usually get on a rant, but this is very important to us,
Yes.
the out-of-pocket expenses. And I just want to be pretty clear about that.
Christy, do you have a question as well? Did I miss you in the roll call? There you are. Hi,
I do have a
Christy.
quick question. It's about the formularies. So I'm not sure if I read the slide correctly, but back on slide 25, I think you were talking about pediatric anticonvulsives. So I'm just curious what the mechanism is. And I don't know if where it says seizure 12, if that's 12 members, kind of what happens when you start to see that maybe there tends to be a lot of people who now are finding success or at least receiving prescriptions that aren't covered by the formulary. Is there a mechanism? How does it work for the GIC to think, oh, geez, maybe this is a medicine that we do need to cover differently? How does that work? Or does that only happen? Does it happen during the middle of a contract year? I mean, I guess I just am curious how that works to adjust as you maybe start to see that people do need a medicine that's not otherwise covered. Thank you.
From the member's perspective, I can say that there is a process in place for the member to be able to appeal to get a drug that is not on the formulary covered. So that process does exist and is available to members. I'm happy to let other folks.
It is actually, most drugs are covered with a prior authorization if it's deemed medically necessary. And the formulary changes about twice a year. And we rely on our PBMs to evaluate which medication should be covered under the formulary, which is most effective. A lot of times when a generic comes into availability, things will shift, and it's also just based on overall cost, and we do assess member impact when the formulary changes. But members are typically not denied medication that they would need.
Great, thank you.
All right, Margaret, I don't see any other questions. So can you cover this appropriately? Because we also have a vote and I don't want to shortchange behavioral health.
Yes, I feel confident.
Okay.
All right.
Thank you.
Thanks, everyone. And thanks again to Lauren for an excellent presentation. A reminder of where Lauren left off to tee me up is she showed some slides that had all of the behavioral health, the THUD access within Massachusetts, and this in and out of network. And we saw there's a lot of access concerns within Massachusetts. And we also saw that there's a lot of out of access concerns in with mood disorders and anxiety disorders. So what I really want to do here is tie those out-of-pocket slides that drill down into behavioral health and our members experiencing access care in and out of network to the current roadmap on behavioral health reform. So commissioners, you may remember that last year you heard a presentation from the Executive Office of Health and Human Services on their behavioral health roadmap to reform. The roadmap is based upon a statewide listening session and feedback regarding the Commonwealth's behavioral health system. Nearly 700 individuals, families, and other stakeholders identified challenges and gaps in the BH system, many of which are reflected in our data from the out-of-pocket report. The output of the stakeholder engagement is the behavioral health roadmap. This is a living document that provides a blueprint for reform across Massachusetts. Again, I think one of Commissioner McEnany's points was the problems are not in the GIC benefits structure as much as they are systemic in Massachusetts. And so if we want to really push access for our members, which we know we need to, we really have to align with statewide initiatives, and it has to be done at that level. All right, so the roadmap itself is focusing on reforms intended to address historical and structural challenges, such as the fact that it's hard to find the right behavioral health treatment when you need it, and it's that much harder to find in-network treatment, as Lauren's report illustrated. Hospital EDs are overutilized as an entry point to behavioral health care, which has led to our current ED boarding crisis. Substance use disorder and mental health care services are not often enough provided at the same location. Culturally competent behavioral health care can be extremely difficult to find. And of course, we saw all of this exacerbated by the pandemic. As part of the focus of the GIC on our 3 strategic priorities, affordability, behavioral health, and health equity, we are aligning with tactics introduced through the behavioral health roadmap to address access within our membership. Next slide, please. All right, let's get right into the roadmap's tactics. The related infrastructure is currently in place to make a measurable impact on access and treatment. This infrastructure will be the focus of this presentation. Specifically, we're talking about 2 key roadmap elements. 1, a central behavioral health helpline that anyone in Massachusetts can call when they are in crisis. Through this helpline, they will be triaged, and crisis stabilization services will be deployed to them if that is appropriate. And this is all regardless of insurance status. This line is live now. It can be accessed by phone or text or through a chat feature on the behavioral health helpline website. We go back to the last slide, please. Thank you. All right, the second key element here that we're aligning with is the Community Behavioral Health Center, or CBHCs. That's the, if we're looking at the graph, there's a blue box around our 2 tactics. First is BH Healthline, the second is the CBHCs. There are now 25 brick and mortar community behavioral health centers across the state where patients can receive mental health care and substance use treatment. In these next 2 slides, I'm going to dig in a bit more into both the BHHL, the helpline, and the community behavioral health centers. I'll provide an overview of what a GIC member's experience would look like today with these resources. And then I'll dig more into what we expect the experience will look like in the future and how we're working with our carriers to ensure we get there. Next slide, please. Oh, I jumped too soon again. All right, I've got one important caveat before we move into the details of it all. We have a particularly sharp focus on our carriers in this space because there is an important caveat around the behavioral health helpline and the community behavioral health centers. The full spectrum of services offered are currently available only to MassHealth members. Okay, this is not exclusionary and certainly not designed to deprive commercial members of these much needed services. It's quite the opposite, actually. The roadmap came about and it leveraged MassHealth's purchasing power to drive behavioral health reform across the market and bring the helpline and the CBHCs into the market. Now that they're here, GIC would like its members to also receive the same expanded access to care and services, and we are working earnestly with our carriers to get there. More on how we're doing this later in these slides. Okay, so now I'm going to dig into this slide in front of us on the behavioral health helpline. This resource is now live with the number in the upper right corner of this slide. The helpline is open 24/7 to anyone in Massachusetts, and this part is important, and it's open to anyone in Massachusetts regardless of insurance status. I'm going to walk through the key element icons on this slide to give everyone a sense of the experience that a GIC member would have when calling the line. First, there's multi-channel access. Members can call or text the helpline, or they can engage the chat function on the helpline website. When they do this, they will be connected to a knowledgeable clinical team. This helpline is run by Carolyn, or formerly known as Beacon, who we're all familiar with, and they bring considerable expertise to this space. A clinical assessment is conducted and the caller is triaged. During this triage process, if a member is in crisis, a crisis stabilization team will be deployed to the member. If they are judged not to be in crisis, the clinical assessment team will then make a referral match for the member and warm handoff. Now, as I said, this is not fully integrated into the commercial market. The helpline does have a very limited number of providers who that can be referred to that accept commercial insurance, but it's limited. And so what we are doing is we are working with our carriers and we are asking them to expand, to help the helpline expand their referral base by integrating their own commercial provider directories into the helpline. What we want to see is a member having access to in-network care that is seamlessly integrated into that helpline for the referral and handoff. And finally, after that referral has been made and a few days have passed, the helpline staff will follow up with the caller to ensure that they got their needs met. Again, to emphasize, we are working very hard with our carriers to ensure that the provider directories are integrated with the helpline. And this critically will enable staff on the helpline to refer our members to an expanded list of in-network providers. All right, next slide, please. Right, now on to the community behavioral health centers, or CBHCs. As I mentioned, we are not yet in a place where all of our commercial carriers have executed contracts with each of the CBHCs. They have contracts with Mass Health, but commercially, not all of the CBHCs are in network. We know from Lauren's out-of-pocket report that we need more BH services in network. And though we need more in network everywhere, we particularly need them in Massachusetts. I don't want to leave the impression that CBHCs will solve all of our Massachusetts members' access problems. Far from it. But I do want our members to be able to go to any community behavioral health center, should they choose to, and have access to the full range of services provided here: urgent care, crisis response, co-located mental health and addiction treatment, as well as care coordinated and connections to community providers. Before moving on, I also want to highlight additional value to the behavioral health treatment continuum itself that may not be immediately obvious. We currently have an urgent care center for medical services, but where do members go if they have a BH need that wouldn't quite be characterized as emergent, but is still certainly urgent? I'm thinking of someone who is struggling, but doesn't need an inpatient bed yet, though they may have this need if they don't get care in the next few days. There's a need for a BH level of care in this urgent space, as many people's current best option is to go to the emergency department. The CBHCs are uniquely staffed and positioned to fill the need for urgent behavioral health care. We want our members to have access to this urgent care, and we are also hopeful that CBHC utilization, as it increases, we see a reduction in utilization at the ED, as well as referrals from the ED to the CBHCs for people with an urgent need, and referrals from the ED to the community, to the CBHCs for patients in need of crisis stabilization services. The expectation is that diverting BH patients from the ED will reduce the amount of ED boarding we see in the Commonwealth. This is something that our Executive Office of Health and Human Services and the GIC will be monitoring closely through our claims data. Next slide, please. This slide summarizes what the GIC is doing to ensure members have an optimal experience with the helpline and have full access to the community behavioral health centers. For the helpline, what this looks like is carriers sharing regularly updated commercial provider directories, and working with the helpline to ensure that members are referred to in-network providers. For the CBHCs, what this looks like is executing commercial contracts with all 25 of the CBHCs, and critically, reimbursing the CBHCs with a methodology and fee schedule that promotes sustainability. This will enable staff to, this will enable the CBHCs to staff as the needs of their panel dictate, and this may vary from location to location. More explicitly, this flexibility to have peer support specialists and recovery coaches when beneficial to patients needs to be built into the financial model and needs to promote disability, flexibility, and sustainability. We'll talk a little bit more of what that looks like in the next slide. Finally, GIC is also monitoring compliance with the recent ABC mental health law, which includes covering mobile crisis intervention, adult crisis stabilization, and youth community crisis stabilization, as well as expanding the BH workforce by reimbursing clinicians in training. Next slide, thank you. A few months ago, we surveyed our carriers so we could assess where they are with respect to these priorities. Here's a summary of our baseline for where our carriers are with this work. As you can see, we have a ways to go with respect to our commercial carriers being better integrated with the helpline. However, each of our carriers expressed a willingness to engage with us in this work as indicated by the orange exclamation point. And on those top two lines related to the helpline, we've got orange exclamation points across the carriers for both sharing directories and connecting members back to care within the health plan. All right, and the next two lines, all of our carriers are currently working on towards establishing contracts with the community behavioral health centers, with MGB Health Plan responding that their contracts are in place and remaining carriers heading toward negotiations as indicated by the clock icon in the table. As I mentioned, we are keenly interested in not just the contracts existing, but in seeing this model of care supported with a reimbursement level and model that sustains CBHCs and sets them up for continued success. As you can see in this chart, carriers are in various places around the reimbursement model too, but we expect to get there. And again, what we want to see here for adult crisis stabilization services, we want to see our carriers reimbursing on a bundle, and that bundle being no lower than the mass health rate. And this allows the CBHCs the financial flexibility to have staff on site that they need. Not every person who walks in is going to need to see a peer recovery specialist, but they'll be there on staff because many will. And really the model that's going to work is that bundle. And the bundle enables each CBHC to staff according to their patient panel's needs. And finally, carriers have either implemented the expanded benefits. This is the bottom two lines on this chart. That they've either implemented the expanded benefits mentioned on the last slide, really around crisis stabilization services, or they're nearly there. We will continue to monitor progress on all of these items until each box has a star icon across the chart. And at this point, I'm happy to take questions.
Let's see. Well, that was a very nice presentation, encouraging. I don't see any questions.
I could just make a quick comment. Thank you, Margaret and Lauren, for your work on this topic. One of the things that excites me about this work is that it's an area where the GIC, with our size, can drive change not only for our members, but more broadly for the commercial insurance space. So for instance, the items under the behavioral health line here certainly will bring, when implemented, access assistance to our members to be directed back to in-network care as opposed to out-of-network care, which we've already talked about being a significant issue here. But to the degree that the carriers would be doing this for us, it puts them in a position to be able to apply this to their broader book of business. So we do this for our members, but we're, as commissioners know, we understand our obligation and our opportunities to drive broader system-wide change in this really important area.
All right. Bobby, I see you have your hand up. Let's try to make sure we don't miss the vote, okay? I know you have a lot to say and I like it, but we also have to stay on time. Oh, you might be on mute. Or you might be mad at me.
I'm not mad at you, Valerie, but I think we need to allocate some time for questions. That's what I think. So I'm very curious, is there a time for, I think, first of all, Margaret, this is terrific. Yes, kudos. It's just great. Is there a time frame for this? Huh?
I don't have my arms around the time frame. I'm happy to come back. The bottom two other roadmap initiatives are more low hanging fruit. It's easier to implement, expanded benefits. The helpline initiative is substantial, and this will also be done in coordination with DOI. I believe there are a lot of moving parts. This is something that's been really hard for the carriers to do. And I am not in a position to make an educated guess of how long this is going to take. What I am in a position to do is keep talking to our carriers and get their estimations and build our timelines and our expectations, and then make sure our carriers are either hitting those timelines or we're, helping them remove barriers where possible. So I see that our role here as really making sure that we're able to shepherd this. A lot of the details on the time are out of our control, but this is an urgent priority of the GICs. So, that survey went out a couple of months ago. We've got our baseline, and what I want to see is continued progress towards that integration from where we are, which is willingness to integration. But again, there are a lot of moving parts.
Right. No, I understand that. Thank you. I sort of, I guess I wanted, do we need to amend because we just entered into contract with the carriers. So do we need to amend those contracts in any way? Or is that just taken care of by the new legislation? Like, is that, do we need to do anything on that end?
Margaret, this may be a performance guarantees question that we may be able to address more in June.
There are multiple pathways. We could come back and talk about those in the future.
Okay, that's fine. That's fine. And just one more quick question you mentioned that there were 25 CBHCs.
Yep.
Where are they located?
Yeah, good question. So what I wish I had done is included a snapshot of the CBHC directory, which is on mass.gov. You can do a search. You can, if you Google CBHC directory Massachusetts, you'll get a website devoted to CBHCs and a map with the a map with the points of where all the CBHCs are, and you can search by zip code. So it's easy to find them. I'm looking at the map right now. We can send you that link. It would have been a good thing to include in this presentation.
Well, I can, you don't need to send me the link. I'm sure I can find
Yeah,
it.
I'm sure you'll find it. Yeah.
So thank you. So currently, at least right now, if our members contact the BH, the
Yep.
health line, right?
Yep.
They're the carriers, right, or not. Essentially, it's the same. Nothing has changed as far as copays or providers, right now.
So if a member contacts the helpline, there is no change to our benefit structure by getting services through the helpline.
Okay, I just wanted to make certain. Yes. So thank you. Thank you for that.
At this point, thank you, Margaret. Thank you, commissioners, for the dialogue on this important topic. At this point, we will hand it over to Jim Rust, our CFO, to walk through the presentation and recommendation and vote on the trust funds. Jim?
Thanks, Matt. Good morning, everyone. Today, I'm here to present the annual trust fund authorization request. As you may recall, these are funds that have been contributed by the employees to the trust fund. These funds are only used if our current appropriation is unable to cover our projected costs or our incurred costs. Next slide, please. Projects that would be funded by these trust funds are reviewed by staff for their eligibility and then approved by the executive director. We have requested these funds as a contingency annually, and the commission has historically supported this request. Historically, we have not needed to use these trust funds for any expenses. In FY23 and FY22, the existing budget has been sufficient. The following slides will show the areas in which we would spend these monies if needed. Next slide, please. So one of the areas where the trust fund pre-authorization request covers is IT projects. So these would be, I'm not going to read all the categories here, but these are the general categories of spending within our IT department. And we would use these funds to benefit the members in these areas if needed. Next slide, please. The other areas where trust funds could be used is for administrative services or training of staff, if there is need for additional training, or to attend conferences that would benefit staff's ability to support members, and also in the communications area for things like video productions and website developments and reporting, ADA compliance, and those kind of matters. The other part of this request is to request the temporary help authorization. Currently, we do not have any temporary employees, but we do ask to authorize the use of up to 10 temporary employees if needed. These employees would probably be if we ended up in an extraordinary circumstance or a need to extend staff, but there is no foreseen need at this time. And with that, I would be happy to answer any questions on the trust fund authorization request.
I don't see any. I just want to hear from you, Jim. Did we spend anything that was requested last year?
No, we did not. We have not for the last 3 years, actually. Since I've been doing this request, we have not needed to spend the funds.
So for those new to the commission or those listening online, we give authorization to spend if it's needed. And in the last 3 years, Jim, correct me if I'm wrong, we have not had to go into these resources.
No, we have not. Again, the purpose of the authorization is so we could go ahead and use the funds if needed and not have to come to the commission in case it was a timely matter or those kind of things. And we report back to the commission after we use the funds. And for the last few years, we have not had to use the funds at all, which is
good. It is good. Excellent. Bobby, go ahead.
Yeah. So, Jim, do you anticipate using them this year?
This year being the current year that we're in, this year we're almost at the end of FY23, and it does not look like we would need to use them. So in FY24, we have budgeted with A&F through our budget process. We think we are sufficient, so I know we don't anticipate it. I would say that things, particularly on the IT side, as we're getting more intense on our IT usage with the portal and whatnot, there's a possibility there could be timing issues. We might want to do a project earlier because it would save us money or that kind of thing, and we could use funds for that. But we don't anticipate that at all. Those are just scenarios where we might say, oh, let's use trust funds to get a project going earlier or that kind of thing, or if we if the opportunity came up to participate in a project that we hadn't foreseen that would benefit the GIC and its members. But again, there's nothing out there that suggests that we would use the funds right now.
Okay, so I noticed though that there's an additional like $20,000.
Oh, good point. Yeah, thank
magic.
you for bringing that
I
up.
wanted to know what that was, because
No, thank you. I meant to stop on that for a moment. Yeah. That's just we've basically have had a static funding request for the last several years, and we're just recognizing that costs have gone up, and that if we were to use the funds, that it might be projects are getting more expensive as time goes on, as everything is, and we wanted to adjust the request accordingly to try to cover any contingencies and not be short. But that's really all that is.
Is that more to do with the vendor or who supports? Like, do you anticipate like an increase like in maintenance or?
No, nothing specifically to any particular vendor, but just general across the Commonwealth, which we have views on and whatnot, like state contracts and those kind of things have all gone up in cost, and we just want to reflect that. Indexing to inflation, if you will, in our request.
And the same with the business continuity, is that
correct?
Similar because of the increase in those costs? Correct.
Right. We do in procurements, not even GIC procurements, but we have a window into what's going on across the state, and we could see that those costs have gone up a little bit, and we're just reflecting that in our request. That it seemed like a good year to increase it a little bit, and we're probably unless we know of anything in future years that would definitely increase the cost, we'd probably leave it at this level again for next year's request. But,
okay.
Just a periodic adjustment, really.
Okay. And I have two more questions. One is about the leased computers, right? Because they're leased for X number of years. So is the lease, is that expiring this year? Like FY23?
I don't believe it's expiring this year. I believe, and then I can check and get back to you specifically. I believe we're in the middle of that lease. That would be more if we needed to add machines or add, right? So that would be additional at the same cost, right? If we new staff or replacement of existing and those kind of things. So that's that area.
Okay, so is replacement like of laptops and whatever part of the contract? Like if you lease a laptop.
No, that wouldn't be an increased cost. That would they replace because we've had this happen recently. Right. The replacement is we're net neutral on that. So it's more if we needed new machines or a different machine or the supporting hardware, those kind of things.
Okay. And my last question, I guess, relates to the temps, temporary employees. Would 10 seems to be a lot, given the small number of GIC staff? That's a high percentage of temps. If you were to need temps, couldn't we reduce that number? I'm not a big fan of temporary employees, although I understand sometimes the need for them. But wouldn't 5 be sufficient if you needed them? I mean, 10 seems to be a lot. Maybe I just didn't notice that,
Well, 10 is,
years.
I understand your points here totally. 10 is a lower number than we have, although we did do 10 last year as a request. It's a lower number than it had been in prior years to that. So I think we settled on 10 as, frankly, probably a round been lower number, but we could bring that back for future years or to make it a lower number. Again, we haven't used any, and there is no plan to use any. So
okay, well, that's good. I'm glad there's no plan. Right. So all right, well, thank you, Jim, very much. I appreciate it.
All right, no other questions. Thank you, Jim. You've got a handle on this. Appreciate it. At this point, I'll entertain a motion to approve and authorize the CFO to pay for certain GIC expenses that's been outlined here, if needed, by the trust funds. So that's the motion. Do I hear anyone wanting?
So moved.
Forward? Thank you, Bobby. Do I have a second?
Again.
Sounded like Toby or Eileen or somebody else.
It was Joe. Yeah.
Or Joe. Okay, good to hear from you, Joe. All right, so I have a second. So at this point, let's take roll call by Andrew. And Andrew, I am a aye.
Thank you. Vice Chair Kaplan,
Aye.
Designee Butler,
Aye.
Commissioner Shabbat,
Aye.
Commissioner Choate,
Aye.
Commissioner Clenard,
Aye.
Commissioner Gentile,
Yes.
Commissioner Guerin,
Yes.
Commissioner McEnany,
Aye.
Commissioner Murphy Rodriguez,
Yes.
Commissioner Sullivan,
Yes.
Commissioner Sinenko.
Aye.
The vote passes unanimously.
Thank you, everyone. And Jim, I appreciate the good attention to detail on budget. I would like to suggest to the team that, investments in technology, making sure that the portal is continuing to evolve to engage our constituents so they can be as educated as possible. They are good investments. So to the degree that we need to leverage these funds to support our members, we have empowered you to do that here.
Thank you very much.
All right, let's move on.
So I'll hand it right back to Jim for the CFO report. And I'm glad we
Matt.
have time to a few minutes to talk about it this time.
Sure. Correct, right. And it's been a few months since we've been back to you with a budget update. So we thought we would go through a CFO report here. Next slide, please. As you may recall, this is the state share expense for all our GIC premium accounts. So you can see the breakdown between all the healthcare and other benefits we provide through April. I'll make a note here, due to the Harvard Pilgrim situation, we have estimated 2 to 3 weeks of payments for April based on prior year's experience, but we expect that to not be material to the budget for the end of the fiscal year. Next slide, please. And this is the mirror image of the state share of the employee share of the same expenses paid from the employee funds. And again, there's estimates here for the Harvard Pilgrim invoices in April. And next slide, please. This slide, as you may recall, shows the shape of the budget over time. So month to month, how we expected to spend the money and how we actually have. And as you can see, the shape has more or less mirrored what we expect, although our budget is large. So those gaps between the blue and the red lines are not insignificant amounts of money, but again, the shape has been pretty much as we forecast. Next slide, please. And the slide is beginning to lose its context because we're getting towards the end of the year, but it projects the spending for the rest of the year. So the blue line projects where we think May and June will be in terms of the shape of our spend. Next slide, please. And this slide shows our total budget, as you may recall. So this again reflects the enormity of the budget, that even though we have a bit of a variance overall, as the budget accumulates over the course of the year, we are fairly right on target for our expenses. And finally, the last slide. And here are the numbers behind the budget. As you can see, we currently project a surplus of about $25 million, which is 1.3% of the budget. Of course, there is a fair amount of volatility around this, and it could move around a bit, but we do expect to be in probably slightly under budget for the year. And with that, I'm happy to answer any questions on the budget report.
How are we doing? I don't see any questions, Jim. How are we doing on our rebates and putting those into our budget numbers? Are those consistent? And coming in for year 5, where we projected them to be when we did our procurement 5 years ago?
That's a great question. Thank you. As you can see, that's a big driver of the spending shape slides that I do are the rebates, because they come in as credits on our invoices. So we don't actually get the cash. We don't get a check, right? We get a credit on our invoices for those amounts. So they have been coming in on the months we expected and in the amounts we expected. So it's been, the contract has been successfully executed on our behalf by the PBM in terms of rebate guarantees and those things. So it has been as expected, which is good news for the members.
Yes, it was very good. So good. Thank you. I'm glad that it's tracking. I don't see any other questions. So
thank you very much. Appreciate it.
Yeah, we can move on. Thank you, Jim, for all your good work. And I know you've taken a lot of the effort for this new procurement, along with Andrew from a contracting perspective. So you and your team really appreciate everything you do for the constituents.
Thank you.
All right, Matt.
So that concludes our formal agenda for this meeting. And hand it to you, Madam Chair, if there's any other new business.
Well, we have 4 minutes to spare. So Bobby, if I took 4 minutes away from you, you can have them back.
I'll remember that for next time, Valerie.
Yes, I wanted to make
You
sure.
can add on 4 minutes to,
if you are keeping track. I do want to strongly suggest to the staff that we nail down an in-person meeting in September, because one of the values of our expertise as commissioners is being able to interact with each other, and being in person, even if it's not every meeting, it is highly valuable to the work that we all do collectively. So if there's a way that you can find a location and set a time for our September meeting, it would be greatly appreciated. And I know several of the commissioners share that interest, not in getting in traffic, but in being together in person. So that's my other business. And now with 2 minutes left, if there's anybody else who has anything, otherwise I will adjourn this meeting.
And we've done this a couple of times today, but I want to thank the commission for your support. I really want to acknowledge the work of the staff at the GIC and our partners at WTW. This has been a very, very busy season for us. And I think you would all be very proud of the way that our staff have supported our members during an extremely busy season. So I just want to acknowledge that at the close.
Yes.
So thank you.
Yes, thank you, Matt, for leading the team. And I know in our June meeting, we're going to get some actual data on all the engagement that we did with our members through open enrollment. So I, for one, am looking forward to those metrics, those data points that support our members, being more engaged this open enrollment. I know that was more effort for the staff. So thank you.
Yep. We're looking forward to that as well.
Yep. All right. Well, enjoy Memorial Day weekend. I can't believe it's next weekend. And, then we're into the summer. We do have one more meeting in June. So we will see you then. All right. Bye, everyone.
Bye.